GMC. So what is the medical simulation exercise all about?
Okay. Uses advanced technology
for educational purposes. In this sense, it allows health professionals to practice and hone their skills in a safe and controlled environment. In this type of training, we use mannequins or simulators, and then we use either virtual or augmented reality processes as well as standardized patient in a safe environment.
Okay.
So that is what is termed as medical simulation.
Okay. So why are these simulation-based trainings important?
Very important because we want to actually phase out errors in the health systems. That is one. The second one is it tries to build their skills in practicing their health at the clinic as fast as possible in terms of working in a team. So we have something like a scenario-based training where participants are put into a group and then they will have to actually diagnose, build their capacities as well. Okay. So these are some of the benefits that we get out of these simulation trainings.
Okay, so who are you training for this batch of trainers?
This is basic emergency trauma course, and it's basically for nurses, physician assistants, EMTs are emergency technical physicians, emergency technical physicians. So these three categories were the ones that we're looking for solely for the BETC. That is basic emergency trauma course.
Okay. How many are they and for how long will they be?
This is a 3-day training. We start at 8 a.m. and close at 5.
Okay. Okay, so what is unique about the UGMC MS?
Apart from that, we have very qualified instructors for the various type of trainings that we run at the hospital. So it makes us very different from others.
Okay. Do you have other simulation-based exercises?
Yes, we have. The next one, which is on the 5th to on the 9th August, is a laparoscopic training for surgeons. Yeah, currently we've moved on to non-cut surgery. So that is what you are going to train other consultants and then EMTs. But the advances for the doctors and the specialists in emergency programs.
Okay.
I would say that all schools, hospitals should come to the medical training and simulation because we are the best of it and we have the equipment to train any health worker that needs any form of training whatsoever.
Okay.
Yeah, our arms are always welcomed. And we have very flexible terms of payment in case they come in bulk for training.
Please, okay. Thank you very much.
A medical simulation exercise is training na yema omo aye adwuma or hospital. Na we no ye use bibi to set toys and machines. The abrofun ye beka se mimic. Ye dey try say yare e wo hospital no ye bitimi aye bi e wo ha na omo aye adwuma hospital na sua ansa na omakọ hospital akoye adwuma. Nti any friend is simulation training.
Okay, and see, other training, I hold all the doors saying that more training some of within.
Currently, the first one I be a laparoscopic training, and we surgery be a yen training pan, yen father yen cut, your friend pinhole surgery. And no, say, I'll call Brucci and Nasa Nanonia, ɛno na sisi a yɛyi so yɛtumi yɛ surgeries bebree a yɛnkate ɛno ne training a yɛbɛyɛ ama ɔmo a ɛyɛ surgery dada anaasɛ medical officers anaa doctors a ɔmo nso pɛ sɛ ɔmo sua saa training no. Next one a yɛbɛyɛ nso yɛ advanced emergency trauma course. Ɛno nso te sɛ basic emergency no. Ɛno yɛ sɛ a wobɛhwɛ obi a wapura sɛ ɛbɛyɛ a wobɛtreat no in various forms. Nsɛ pra no bebree yɛ different. Nti nea onipa no de bɛbɛ bi ɔsɛ ohun kwan a wobɛfa so a wobɛhwɛ no. Nti yɛde ɔmo fa saa ntetie ne nyinaa mu sɛ ɛbɛyɛ emergency case bi a ɛyɛ trauma and accident case no wobɛtumi akita for them worldwide and across board.
Hia bɛ na ho hia sɛ yɛ such simulations training.
Ɛboa esan sɛ onipa no ɔkyerɛ no na onimnimdeɛ wɔ ho a ɛma ɔmutumi hwɛ ayarefoɔ no wɔ hospital yie. Sisi ano nea ɛha yɛ health facility ne sɛ ɔyarefoɔ bi ba emergency ne ya na ɛtɔkyima kakra esan sɛ to de bi a na nea wɔ duty no ehu sɛ ɛbɛyɛ a ɔbɛhwɛ nipa no. Nea good thing about it ne sɛ ha yɛnsi nkurɔfoɔ nti ɛyɛ a nkɔ akyiri but wohwɛ wɔ hɔ paa nti mefele sɛ yɛboa sɛ yɛbɛtwe ne ɔma ɛbɛyɛ amɔma mu no nyinaa sɛ ɛbɛyɛ a obi ɔbɛba hospital no obɛnya na yaresa pɛpɛɛpɛ sɛ nea yɛhwehwɛ no.
Then ma nea UGMC form simulation training wɔn yɛ hɔ anom so no ɛda nso ɛyɛ sonko.
Yɛda nso wɔ bebree san sɛ wohwɛ yɛ facility a yɛwɔ a menyɛ sure sɛ ebi wɔ Ghana memua even the whole of West Africa yɛnni bi wɔ ha. Yɛ toso mienu yɛwɔ very qualified yɛ from instructors and as trainers ɔmo ɛkyerɛ no very qualified ones a ɔmo de nkurɔfoɔ fa ntitie mu ɛma nea ɔmo sua no ɔmo nya ne sɛnea ɔmo pɛ. Yɛ toso bi yɛwɔ mannequins a etimi ne nipa kasa nti utimi setting up nicely ma etimi yɛ sɛnea ɛwɔ hospital ne pɛpɛɛpɛ. Saa nneɛma ɛwɔ a yɛwɔ no ada facility ɛnni. Ɛno na ma yɛ dance.
Okay, nti wo bi fufuro opɛ sɛ wo kan.
Yes, me obi fufuro esan sɛ me person ka bɛyɛ a ka hospitals and training schools nyina emba on board sɛ ɛbɛyɛ a ɔmbɛba bɛgye ntetie. What yɛ pɛsɛ build up the health system. Nti so mtimi ba yɛ betimi aboa ɛwɔ kwan bia so training bi ɔmo hia bia yɛ betimi aboa ɛne ɔmo ntetie.
Kwakwa foto mo re ma wo ma ho ba bɛgye saa ntetie.
Wɔn abɛgye santiti yɛ mɛka ne sɛ esikatia kakra wɔn but ni sɛ wɔn hwɛ sika no esan sɛ ntete na wobɛnya fi saa adesua wobɛsua no ɛbɛboa wɔ abrabɔ sen saa sika kakra na yɛbɛgye wɔn nti ɛbɛyɛ a wo a wobɛhu training biara ka yɛbɛsoso sɛ bra na bɛtia bi sɛ ɛbɛyɛ a nso wobɛtumi akɔ anim ɛwɔ wɔ nipa ahodoɔ no depend sɛ yɛka sɛ basic emergency trauma course na ɛno yɛayɛ ne basic for nurses anaasɛ physician assistant anaasɛ emergency medical technicians ɛna sɛ wohwɛ advanced trauma course na ɛno wɔ soro kakra nti ɛno yɛ specialist in emergencies and any other medical personnel na professional a ɔyɛ advanced ɔpɛ sɛ ɔyɛ training ni bi. So oba laparoscopy no so eno nso ye surgery asenia mekan no ye ntwa ye pinhole surgery na ya amount the same day obetumi akofie nti eno for surgeons a omo ye operations dada sesi a ye mpese ye betwa surgery nti ye pese obi ehu sa type of surgery no se be ya ye betumi imitate ni a abrofo no so ye ewa amanane no eno ni training programs a ebi o ha ya hihya etoato aso a ye be ye.
All right, it does.
But you did not hammer much on the medical errors now, for which reason you are having this training. Can you go over?
Yeah. Senior Mikani, Ceciano is brothel. In Pempino, and Crofoko Hospital. Feedback and I said, and someone be Babacano and Shemi ye, nurse where I say, doctor where I say. Eto de bia na ohwe ana yampa eno ne ye pese ye bo e homrodin se sa ensem na ye asisi hospital no ye try as much as possible na ye bo e homrodin se ka ye be training profo na omo ye perfect nti omo pa be ye adwuma na unya asem bia nka omo na se omo be ye omo adwuma pepepe eno nyina nti na ye simulation no esan se we o de toys e na ye adwuma and you are working in a risk-free environment, you find set toy, who person certain line manner, what me ye will nipa ho a was at least what me back. Why it is why you but I told the baby see a war on someone who threw just for taking one sample, and when you try see a better try say be eradicated win it was system and only medical errors.
But I'm more sure say homogeneity juma.
Yeah. Senior training it no. You see you perfect before you go. I just say who pass it procedure na and sana your mouth certificate. And the fan say what ba say who between in so will be a your friend lamba puncher. You be making sure say obey severally. Not what perfect into say once a winning ye no. Uko nipa no ho a ya kire o landmarks ni nyina ana baby potin also de panene hye into di hye ya wo se utiminya ni a ohwehwe ehun tochima.
Okay, I think let's do
There implementation of healthcare services, and I cannot list them all, but it depends from department, but the most common ones are negligence from the health workers, and sometimes it's not negligence, it's just not perfecting the procedure the person is doing, so they tend to perform badly. Let's say the person is taking a sample, so instead of just going in to take one at a go, the person goes to several points just to puncture a vein to get a sample, and sometimes they do it without even getting the sample. The place become a bit tissued and land the patient into another health problem altogether. So it depends on different area. Yes, but most common is negligence. That's equally another head. But then the main issue is what you are supposed to do should be done well. Once you are trained to do it, you should be able to do it well, and that is what our main focus is. Once you are supposed to do the work, we want you to perfect the skill and then do it well.
Okay, so perfecting the skill is a game changer.
Yes, perfecting the skill is a game changer when you talk about simulation training.
Thank you very much.
Patient's airway is not protected. Okay, it's not protected. And if you remember the protection that Agala talked about, he was talking about the fact that the patient cannot aspirate. The protection, yes, protection against aspiration. Protection and patency, they are different. Patency is the pathway open. Okay, that's how we are looking at obstruction. The pathway open. If it's opened, then the air can go down into the lungs. Okay, but the protection is, can this patient prevent aspiration? Okay, so if they cannot prevent aspiration, that airway is not protected. And the way to protect that airway was what he was talking about, that if you have a tube with a cap below the vocal cords, yes, okay, below the vocal cords, and then you inflate it there, and then you will connect it to oxygen and secure it in place. So there are components of it. A tube below the vocal cords, okay, that is one. Secured is another, connected to oxygen source. Okay, there are components of it. So all those components should be there. That's how come he said that if you have a laryngeal mask airway and you put it there, because it's not below the vocal cords, it cannot protect the airway. Though it's called advanced airway, it doesn't protect the airway. Okay, so you must have a tube, and this is one of the tubes. And can we get an LMA? LMA. So this tube, and if you look at this structure here, is anybody able to identify the vocal cord? You can see the vocal cord? Yes, exactly. So over here, I don't know. Let me use. Okay. Here is where the vocal cords. You see where the blue thing is. That's where the vocal cords are. Okay. So the tube should go below that. The tube should get below that. Okay. That is where you want the tube to get below. Okay. So when we intubate, that's where we put the tube. Okay, so you want this tube. So let me show you how this tube. You need 10cc syringe or some syringes. Yes, can you do that for me? Because there's a balloon here that you would inflate. Okay, so you want this tube to go down, down there. Okay, and you inflate the balloon below that vocal cord. So that balloon goes to fill that trachea.
Please,
and
the local cords again. The vocal cord, sorry. Up or down?
It goes in, let me use this one to show it. Here. Okay. Yeah, exactly.
Okay.
Most of the time using a diamond shape something. Where the thing is entering.
And it has to go below it.
Yes, that vocal cord, the tube, the cuff that you are going to blow should be below that. Yes. There's a, oh, okay. Have you found out from there? Find out from the staff over here. They have a store. And each size will determine how deep you can push it down. So what it is that generally what you do is that the size of the tube times 3 is the depth at which you push it. So this is size 6.5 times 3 is what? 19.5 or something. 19.5. So when you push it, you see there are demarcations on it. This is 16, 18, 20. So 19 will be around here. So when I push in this tube, I will push it till the teeth level. So tip to teeth should be 19. So yeah, it should be around here. So that's where I'll push it down to. Okay, 19 will be down here. So tip of this to 19. Yeah, okay, good. So that's what we will do. But the most important thing is to listen to both sides of the chest. Is the breath sounds equal, symmetrical? Because that would what will tell me. Because at times when you push it too much, it usually go into the right, and this is what it has done. It's going to the right. This is the right. This is the right side. So you push it, it goes into the right. So then, if it's the lungs, see that you'll be putting air in the right side, but the left there's no air. Like if you push it too much, so you think, oh, I've seen it. Let me push. And you're pushing. That's what happens. Okay, it goes into the right side. Okay. So then you always have to remember where it's supposed to be. So we want it to end from just around here, the carina, so that it's not in the left, it's not in the right, it's just above it. So that when you give it can give the air, oxygen, have some going to the right, some going to the left. Okay, so you always have to listen to know. Though we have the rule of thumb that's multiplied by 3, so that you know where to go, but you still have to listen because at times it's still too deep and you need to come out a bit. Okay. So that is about intubation. That's really about intubation. That's what really happens when you need to intubate. And so if you don't have anything, because the laryngeal mask airway, when they bring it, I'll show you, it doesn't go below the vocal cord. It just comes to sit on top of this. And then when you give the air, it goes in there. So in terms of protection, it doesn't protect. This one, when it goes down there, the balloon is inflated, it fills the whole of the trachea. So it doesn't allow fluid and secretions and others to go down. Okay, so it goes to sit in there, you blow the thing around it, it fills the whole place so that nothing can fall from up here because of the balloon that is there. So that is why this is called this is a definitive airway. Okay, but the laryngeal mask airway and the combi tube and all those things are called advanced airway. So they are not really protecting the airway, just that they can help you in giving oxygen and stuff like that. So normally this one, when they pass it, this one goes and sits in the esophagus. It goes down to the esophagus. Sorry, let me do it well. It's difficult to use. Okay, I will probably do it. I'll do it later. But what happens is that this goes to sit in the esophagus. You blow it. This one also sits up and is blown, and then the apertures or holes are here. So then, if this one has gone to occlude the esophagus and this one is occluding up here, it gives you the air, and the air goes into the trachea. But still, because nothing is sitting below the vocal cords to occlude the trachea, you can't say this is a definitive airway. It's still an advanced airway. Okay.
So this one probably maybe prevents the aspiration or the stomach contents from coming out.
Yeah, but it's not. It doesn't really occlude it so completely well. But it may help a bit, but it doesn't really solve the problem entirely for you. Okay. All right. So these are the advanced ones, but in terms of the combi tube, yes. You got some for us? Okay, so this is the laryngeal mask airway. Okay, so the laryngeal mask airway, we need to know what size will be appropriate for the patient. We need to know. Okay, so before I come there, let's talk about the oropharyngeal airway, because when in terms of, so we say that the patient's airway is not. We need to manage that airway. We want to open the airway in terms of patency for the airway. We need to open the airway. We talked about jaw thrust, isn't it? The jaw thrust is one way to open the airway in a trauma patient. Okay, so how do you go about doing that? Okay, so with your fingers behind the mandible, so you can all feel your mandible, the angle of your mandible, it's almost here. Okay, you can move your mandible forward. Can move the mandible forward. So I put my hand behind him and I move his mandible forward. You see some movement? Yeah, you move his mandible forward. And what that does is that because the tongue is attached to the base of the mandible, once you move it forward, you're able to lift it off the oropharynx so that it doesn't obstruct the oropharynx. Okay, so that's what you do. But once you've done that, you can't keep on doing this forever, isn't it? Because once you let go, the tongue will fall back again. So then what do? Then you need to put in your oropharyngeal airway to keep it patent and to prevent the tongue from falling back. Okay, so that's what you do. But you need to determine, there are different sizes. Look at how big this is and look at this one. So there are different sizes. You need to determine what size will be appropriate for your patient. So you need to size your oropharyngeal airway. And how do you go about that? Okay, ear to the corner of the mouth. Okay, so some will say from the tragus, that's the tragus, this one, the tragus of your ear to the corner of the mouth, you measure it. Okay, so this one, if you look, is too big for this patient. Okay, so let's see this one. Yeah, looks like it may be okay. Okay, so if this is the one that is the one we're going to use, there are ways that you can go about it. Okay, you can decide to put a tongue depressor. Okay. Okay, I would assume this is my tongue depressor. Okay, so I go in like this, depress the tongue, and then I go in and put it there straight like that, and it's there. Okay, that's what I can do. The other way is I can go like this. Okay, I put it in there, it hits the hard palate, then I rotate it 180 degrees, and then it goes in there. Okay, are we okay with that? Okay, all right. So that is about the oropharyngeal airway. So you put in there like this. Once you put in there like this, you can put your orbiter back on, and then they get oxygen. You provided some patency. Then the patient was earlier on snoring. The snoring should stop like that. Okay. All right. So that is the oropharyngeal airway. Yes.
So before you put the oropharyngeal airway, do you have to lift the jaw?
So I think I was doing the jaw thrust. So once they come in, they size it, they can put it in there after I let go of the jaw thrust.
Okay, so it's not necessarily one person doing it.
Oh, no, it's not. I mean, when it comes to these trauma, maybe the other thing that if we didn't mention that you need to always call for help. I mean, you need to get help, just like we do for ACLS. I mean, get help, because you can't do all the things by yourself. Yeah, because even if you remember, when we're immobilizing the cervical spine, you do this. The person comes with the cervical collar. You don't let go to go and put the collar on. You continue holding, and they will put the collar on. And then when they put it on at the back, then the front, they put it on before you let go. Because other than that, what you want to prevent, the neck movement, can happen as they push the thing under. Okay, so you don't have to work alone. You need help to work. Okay, so you have put in your oropharyngeal airway, you put it on back your mask. Let's say that is going well, but this patient, just putting the oropharyngeal airway does not protect the airway. It's just there to provide patency. Okay, but this patient, you think that this patient will need further airway patency or even oxygenation or something like that, then you may need to consider intubating the patient. That's what we're looking at. Okay, so if you need to intubate the patient, then you go ahead and prepare for them to come and do the intubation, because mostly you won't be doing the intubation, but at least you should have a fair idea of what it is that needs to be done, so that you are ready for the patient to be intubated. Okay, so what are some of the things that you need for the intubation to be done?
Medication.
You need medication, so you need to prepare. And for me, in my head, the acronym that I have in my head to prepare to do the intubation is called SOAP-ME. SOAP, seminar. SOAP-ME. So S is for suction. So your suction and the suction catheter, the pressures that it comes and all that, you should ensure that the suction is working. Okay. The O is oxygen. If you don't have oxygen in your facility, you need a cylinder and all those things. Get them ready. Okay. If you are aware here that you have the oxygen through the pipes, you don't really worry that much. But oxygen should be. You need to think about it. Okay. Then A will be the airway adjuncts and equipment and stuff like that. So the oropharyngeal airway, nasopharyngeal airway, you need to consider all that. Okay, even the intubation, the ET tube, the sizes. So we'd say that for a female adult, you can do 6.5, 7 ET tube size. You see the size as I showed you, it's written on top. The 6.5. Okay. So you need to get 7, 7.5, 6. I mean 6.5, 7, 7.5 for female is okay. Males 7.5, 7, 7.5, and 8. Yeah, will be okay for them. Okay. When it comes to children, it's slightly different the way you work with that.
So that's why you write the time. The time you apply the certificate. Because after about 45 minutes to 1 hour, you should release it again. No. You release it small. No, just so that blood can measure some blood, because they have some Bible teachings. They just around the flow of blood to that candidate. And then you apply again. After you release more for blood, especially you have to look at the time. The time. So once you do this again, you have to, you know that the time will change.
Yes.
I hope you understand. So you don't keep the same time. Okay, your time will change.
Yeah, that one to another 45.
So this is another 45 minutes. But it all depends on how where you are going, the distance.
Nearby facility.
Exactly. Are we okay? So this is how we apply tourniquet. Okay. All right.
Dr. Kala, the tiny tourniquet from our giving said that we use, is it advisable?
A tiny tourniquet from our
Like we use, some people use wire, improvise, wire.
they are not effective. That's what I'm telling you. All right. They are not effective. This is what the soldiers use.
What's the name of this tourniquet?
Can I release my hands now?
Combat something. I've forgotten what the A stands for.
So I've heard it, but I didn't know it's this one. I've not seen it
But
before.
I've forgotten what the A stands for. Like,
It's in the red tourniquet. Let's do it. Nice.
so it's combat application. So
It looks like
yeah, you don't check pick this one. And I didn't want to believe. There was a day. I remember there was a time. All we had there was there.
And about
there was
25
we
mils.
didn't have the pink one. So my thinking was I want to procure this. They have
Yes.
made a mistake, not knowing we
100 mils per minute.
we have
Can
orange
deliver 100 mils
candle.
per minute.
Yeah, so orange.
Within 2 minutes, 500 mils will be gone. If you get a good line, yes, we open it fully.
Within 2 minutes.
That's what they are saying.
And
That
then
is the
this,
best.
300 mils.
this is your
mils per
condom
minute.
catheter.
It's like the
Plaster in it. So there's a plaster to help you secure.
Okay.
Let me see whether
Sorry,
So
for the
this
urine bag.
this one is for the urine bag.
Yes, so you can actually open this and
So you improvise your hand as the penis, the bigger one. Okay, 2 penis.
Or it should be bigger than this.
So you
yes.
I calculate. You see, like this. Okay, you can bring your penis. So
Put
then,
it here.
so
It's 10.
like this. Then like the normal rolling.
Then the infection, how they
And you see there's a plaster in it.
Then you want to get this plaster.
Sorry.
So then this is for the males only.
Only have it for the ladies. If you do it,
Oh, then this is
yeah, but you need to assess the size. It comes in size.
So this one you don't need to.
Yes, sir.
who knows?
Right. So this is how it works. Okay. So okay. Don't do it. The other group will also come in then.
Okay.
So on one, the other thing, how do I call it? So the good thing with this one.
In fact, this is large.
So, so the good thing with this one,
We have sizes.
you reduce all those how do you call it, infections, the trauma you girls normally cause to our ureters. You how do I call it, circumvent all of that. I hope you understand me. Right, and so that's why I'm always advocating for the condom catheters. But for those who may come with things like prostate problems, urine retention, I mean, they are not even able to pee by themselves, so you need to help them. So for them, you will need the transurethral catheter. I hope you understand me. Otherwise, if it's just for checking, I've come to you, you want to check my urine output, and because of that, you want to pass the catheter. Hey. I hope you understand me. You know, females, we don't have it. But the other issue is, and they would, but you see, if you really look at the issues of catheterization, it affects males more than the females. Oh yes, it does affect males more than the females. The discomfort and the problems.
Urethral infections more than.
Sorry, no, they have a very shorter urethra.
So this should rather suffer than us.
Yes.
This rather suffer.
He's talking about injuries in terms of
Trauma.
No, so if a fracture is here, this has to come above it. And if the first one does not, how do I call it, help in securing the hemostasis, you don't remove it, you pick another one, and then you go above this one. So I apply this one, the patient is still bleeding. I did it very well, the patient is still bleeding. I don't remove it, I take another one, bring it here, then I apply.
Dr. Gala,
So you don't go below the injury.
No, above the point of.
won't it cause the leg to be
Funny.
Yes, so you're actually cutting off blood supply, and that's why you put the time here.
necrosis?
Yes, that's what I'm saying. You put the time here.
The time you
Okay, so you put the time here, and then so some books will tell you 30 to 45 minutes. Okay, you release it more. You allow for
blood to
flow back to the peripheries, and then you tie again, and then you move.
Alright. So this one can be the releasing and the tying can be done when the distance is far from the.
Yeah, it's very far. It's extremely far. Yes, and that's what you do. But if you get to your next destination in the next 20 minutes, you can leave it, and when you get there, they'll fix it. Have you understand me?
Yes, please.
All right. So please, there's some few seats here. You sit down. Let's do something quickly. Okay. So, and then afterwards we'll act a small play. Okay, and I would want you people to bring to play or to bring to bear all that we have learned. Okay. After this, we'll act a small play. All right. Let's do this. Splinting. What is splinting? And what are the advantages of splinting?
To immobilize.
Immobilization, yeah, so we immobilize how do I call it, the fractured limb. So you want to keep that particular limb in alignment, intact. Okay, so what are some of the
prevent puncturing or cutting
major blood vessels? What again?
To prevent the bones from also shifting.
Okay.
To reduce pain.
To reduce pain, even to help, it also helps to reduce hemorrhage.
Yes.
Okay, so bleeding, if it's pain, it can help to reduce it. Okay.
Yes, please.
There are principles of how do I call it? There are principles underpinning splinting. Okay, I know we've been doing it. We've all been doing it, haven't we?
Yeah.
Yes. Okay, so I'll call one of you here to show me how you do it. So let's just say that this man. So for the purposes of, we're not going to use the POP. We're going to use this as our splint. Okay, we're going to use this as our splint. Okay, we're not going to use the POP. Right. So for the purposes of, okay, we're going to use this. Okay. So it just so happens that this man clearly has a deformed extremity, okay? The left lower limb, it's broken like that, bent like this. Otherwise, he's conscious, vital signs are fine, and you want to apply a splint. How will you go about it? Please, do us the honor. Let's go. If you need help, you can call on anybody.
Okay.
Let's go.
No, please. I'm calling you now.
What's the first thing you do?
Okay, so we've done the...
Yeah, we've done the airway breathing and all. You want to explain this? It's bent like that. Patient is screaming in pain.
Analgesia, conscious sedation.
Have you spoken to the patient?
No, not yet.
Okay, so talk to the patient. Okay, cool. Your friend Susu.
Mr. Susu.
Yes, hello. Me bro.
Naya, what's our expensive? How do you say?
To splint.
I don't know see. Send a bay, I be bro, ya on a kakar.
Yo, we don't need them.
Okay, so we appropriate down in way of fees.
Alright.
We listed.
We hydrate in analgesia.
Yes, so you tell us that maybe you've given your pain.
Which pain medication? Okay, give me a pain medication, that's fine. Alright, that's fine. The leg is still hanging.
Measure whether there is a
You instruct him what you want him to do, rather than that he wouldn't mind.
If you tell me what to do,
Yes, I don't know.
So the,
check
the,
whether
the
there's
frac-
a short-term link.
yes. So there's an obvious fracture. Is it open or closed?
It's closed.
It's closed.
Okay.
Okay.
Like that.
Yes, it's 10 like this. So we measure, see, there's a joint here. This is the knee joint. It's a joint here. The fracture is the tibia and fibula.
Yeah.
So these are our splinters longer than this patient. So we are wearing our gloves. So given the pain is probably pain has gone down. So we want to reduce and put the splints under the affected limb. Okay, so we are wearing our gloves. So you are doing it. So I am holding it. Sorry. Okay, sorry. You come to this side. Sorry. So your bandage.
I say I'm not paying a now.
Okay, pause. Okay, so I like the bits about the analgesia. It's important, okay? Every time we like doing this thing without analgesia, it's not the best. Okay, that's one. You need to tell the patient what you want to do. That's two. Thirdly, you have to assess the neurovascular status of the affected limb. So it was like that. You have to check first. And you don't just only check this one, you check the two. Why? Because sometimes you may feel some pulse here, but if you were to compare to the unaffected one, you'll notice or you'll realize that this one is being stronger than this one. Very, very important. You also have to ask if the patient can feel. How do you understand me?
Before you even do this.
Yes. Before you even do the splinting. You have to check. So you check before and after.
X-ray before the
Sorry?
splinting.
No.
But Sagala, can you also tell the patient to try moving the toes to see if he's able to move?
It will cause a lot of pain.
Flanking.
Sorry?
Yes. Just flanking on the toes.
But what for?
Since we are checking the
sensation.
not just the sensation,
But
we
the
are checking the
Well,
neurovascular.
you code, but I mean, don't do anything that will exacerbate.
The reason I'm asking this is, I think 3 days ago we had a case like that. There was an open fracture. So after they had done the splinting and all that.
That's after.
No, before, as in they immobilized it because he was bleeding. So something like a tourniquet. So before they took to the orthopedic ward, I remember the doctor asked, the specialist asked the MO if he had checked for the neurovascular status.
You could. There's nothing
So
wrong with
he removed the bandage to check both legs.
You could. There's
Before
nothing
I
wrong
think.
with it. You could, yeah. There's nothing wrong with it. Okay? So that's what you do. That's one. The other thing you didn't do correctly is the fact that you have to measure with the unaffected leg. Okay, so you don't bring this directly here. Okay, mind you, we are trying to get this affected but to look like the unaffected limb. Okay, so you're going to have to do this. Now the principle is your splint. You see, the whole idea of immobilization, you don't want the limb to move. Is that not because it moves, it causes pain, it can lead to the clots getting dislodged and bleeding, resuming and all of those. You don't want that to happen. Okay, so if it is on the shaft, you want to immobilize the joint below and the joint above. So you can't just do a splint like I see people do. Someone comes with some small, how do you call it, some fracture here. So if this is the knee, you just put it here and then you just bandage it and then they are done. It will still move because the knee is here, so it will still work. You can still move if you want to move. And so you don't really achieve anything. The best way was to cover all this so he can also even want to do that.
It has to go beyond.
It has to go beyond. So it has to be the joints above and the joints below. Have you understand me? So what I would do, what normally you would do is you want to measure this first with this one, okay? So let's say the fracture is here. So you start from maybe somewhere here, somewhere here. That's fine. So you're going to end it somewhere here, okay? Right. All right. So you take this, and then you can't do it all by yourself. You need to, because you see, the muscles have been stretched because of the displacement. So one person cannot just hold. You need two people. One person to hold this side, one that holds this side, and then we do what? And we try to what? So we are trying to what? Realign. We are trying to realign. It's not just putting something together. You want to realign it. Yes. So we are reducing it. Okay, so George, for instance, he will come and stand this way, and then hold this way. Okay, yes, and then we are reducing.
That would be so painful.
That's why you have to give you adequate
Sorry? No, we are not pulling. What are you saying? Then with this, you put this behind all the way down. Okay. Then you put this. Good, nice one. And then you bring your bandage. Okay. So if you don't let go, you hold until it's been bandaged. Okay. Where do you start from? Yes. Okay. So normally I will probably start from here. Okay. Go 1. Okay. 2. Yes, and then this next one. Come this way. Come that way. Okay? And then you can start your. Yes. Okay.
The leg is moving.
It's moving. And so because I'm holding it, that's why I'm just trying to show you, and then you continue. Okay. You keep going. You keep going. Keep going. Keep going. Keep going. Keep going. All right. It's okay. So we are done. So we've done it. Now you don't end there. You have to go back and check your neurovascular system. Then you talk to the patient that we are done. That is how we go about explaining it. Sorry?
Since it's a closed fracture, yes, so there's bleeding internally.
Not necessarily. The fact that it's a closed fracture does not mean that there's bleeding ongoing internally. Okay? Yeah. Here we are just splitting. We want to realign the bones. Okay? To reduce pain, to facilitate bone healing, to also prevent injury to other structures. How do you understand me? Yeah, other, how do I call it? Nearby structures, the vessels, the nerves, essentially. How do you understand me? Right. So that is how you go about it. Okay, if you have to splint, it's simple, but it's not so simple. Oh no, I stopped it because we actually bandaged all the way. I stopped it because I didn't want us because the same. How to understand me? Alright, so you get the principle, right? Okay, that's fine.
The same bandage and I think we don't use a crepe bandage.
Well, that's what we use.
No,
this is crepe.
This is crepe. So
Yes,
the one that is like the gauze bandage. And then we don't use that one.
Why do you think so? Why do you think we don't use it? Because it's inelastic, right?
Exactly. So it's,
and you see, you notice that normally for the clothes, even the open fractures, you have to do this. This is what we call it the back slap. Okay. You see, so it's just on one side, preventing what? Immobilization, restricting movement. How do you understand me? In the immediate aftermath of any injury or these fractures, there is what? Bleeding, or there is what? Inflammation. So there is edema. Now, if you were to do a full POP, a full cast, where will the edema, the expansion, where will it go? It will end up causing compartment syndrome. Okay, and that's why the immediate aftermath, you always do a back slap. Even though to say you do a back slap after some 1 week, and they tell you to come back, and they will convert. By the time the edema, the inflammation will have resolved, and then they will now go in and then do a full cast. How do you understand me? All right. So this is the principle underpinning, how do I call it, back slap. Is it clear?
yes.
Is it clear? Okay. So I want one of you to also come. Sorry? Yeah, so someone has a... So I have a humeral shaft fracture. I have a humeral shaft fracture. Who would want to help me?
Humeral shaft fracture.
Who help me? To help me? Oh, it doesn't matter.
All the two. Humeral fracture.
Yeah, so a humeral fracture. Yeah. Please. Yeah, so yes. Please let's give it up for her. Let's give it up for her. Thank you.
Okay. And this part is already.
No, it's me, it's me.
Hey. Hey, we are direct.
yo.
But we've done all the basics. We've done the vitals and everything. And this time is the arm.
Is a humorous, yes.
The humerus.
And then you can see
Yes,
there's a clear
so-
deformity here.
So just like the first one, we will give analgesics
Yeah.
to ease the pain
Right.
immediately. The pain a cough.
Okay.
It's
Magical power.
very powerful.
Yeah, dear.
And so we are going to this alignment. Yes, so with the alignment, we would measure the unaffected arm. But I'll need assistance.
No, you're using you.
Use your arm. It's just the arm. It's your arm.
Maybe your trainer, I pass all that.
No, it's fine, it's okay. Yeah, I just want to see how you go about it, that's all.
So we found everything, we've given the analgesics. So we are going to splint the unaffected one.
You are going to measure the
Unaffected one, yes. So with the unaffected one, I need 2 people. Oh, this one is 1 person. So the rule, we say above the joints and below the joints. So there should be around the shoulder. It should be around. Around the shoulder.
It's above. How should your joints?
Here and here. So like this. And then just go
All right, that's fine. So yes, you get the principle, right? But okay, so for the it's fine. You get the principle, but for the
When you said we should do the neurovascular assessment.
exactly.
You know what the first thing you're supposed to do? You assess the affected arm.
Yes, you compare
We
which
have to
ones.
still assess
What you
whether
do the
there's changes.
just to be sure. Yeah, let me sure.
Then you move the finger.
Yes, you tell the person to do this, and then you check for
Yeah,
sensation, that's fine. The other thing is, for the humerus, okay, there are 2 ways you can do it. You can either do what you call a U-slap, okay, or you can do a sling and swap, okay. With the use, so it's a U, okay. So you do the measurement, and what you do is that I'm going to put this here like that, like a U, okay, and stretch this all the way up here. So that's a U slap, okay. You see, now we now stretch it somewhere here. How do you understand me? And then you hold it with your how do you call it? With your bandage, and then you can give a
arm sling.
arm sling. So that is what we call the U slap. You've seen that? Okay. I do know some people still just stretch it.
Yes.
Or do it this way. And then they just how do you call it? Well, it's better than nothing. Or at least even in this position.
Then even after that one, will they still give you the?
No, if it's done,
but the best, like I said, the best is the U swap, the U slap, okay, or what they call the coaptation splint. Or the other alternative is you do what you call a sling and swap. How do we do that? Who knows how to do a win for us? Can you provide us a win for us? An arm sling for us? Who can? Who can? Please do it. No, Sandra should help us. Sandra is so quiet. Sandra should please help us. Sandra, please come. Let's do this quickly. Everybody is coming to do something. Let's do quickly. So we can act our movie.
Is that how?
It's your eye. Okay. She wants you to test that the world will see you.
Fred, what's your name?
It's very confusing. It is confusing. Nafafa and the corner send me you splint it like this. So
that one over there.
Then
That's a over color.
that's the way they see. At least we are actually 20 years.
You're who you are
Eventually.
Hey, you
What's the thing that's not saying? The more you lose.
So let's do this. This guy, let's do this. So I mean, there are no hard and fast rules for it. Listen, you can do it anywhere you think it fits for you. Okay. So normally, this is the confusing. Confuse all of us, not only you. So you can have your sling, and then here sometimes dealing with this part is a problem. Okay, sometimes some people will just use a how do you call it safety pin to just hold it. Sometimes if you don't have it, you can tie it. So you can tie it and just fix it inside. That's all. You're done. Okay. If you want this to come up, then you make sure you pull this one higher. Have you understand me? And then it will come up. Have you understand me? So yeah. So for a human factor, you can do this, but that's not all. Then you take your bandage and then you tie to the body.
To immobilize it.
Sorry? So that's what we call a sling and swat. So this is the swat and then that's the sling. So you are holding it, you are pinning it onto the body. I hope you understand me. Yes. Do you get the principle? Okay, alright. Please. Where is it Carol? Carol, please.
There's one that they have been hanging their hand.
Which one?
The one that they went to, after the sling. Not the sling, they hang Not the sling. After the back slam. The back slam. They want to reduce inflammation. So
oh, no, okay. So that one, they just hang it because, so if you have a fracture here and then the whole place is swollen and all that, okay, so they just hang it just so that the inflammation will reduce. Basically, that's bleeding. Yeah, and also to reduce bleeding. Yeah, right. That's what it's happening to. Okay, right. Please. And when we finish with this one, we act a movie, a big one, a small movie before we close. Okay, so please, please come. Let perform this thing on him quickly. I'm coming. I'm coming. I'll be here in a minute.
Yes.
No assessing my courses.
It's true, so you assess the houses.
So this is mine.
Good. So you do the first. Do the good one first.
Introduce the materials.
There was this preacher man, Dan?
Yeah.
So there was this preacher man by the roadside. Just as he was preaching, the driver who was drunk skidded off the road, hit him. As a matter of fact, the car ran over him. The car ran over him.
Right. Going to heaven straight.
and this man was picked up by bystanders. Was picked up and then rushed to the nearest facility. And you happen to be the nurse on duty. Please. 1, 2, 3, and 4. 1, 2, 3, and 4. Approach and then manage this patient. We have just 10 minutes. I have to teach you log rules, so let's hurry up.
Go to check. Emergency. So we have.
Yes, so the patient. Yes, it's told people. Yeah, you don't your protective clothing. Okay, let's go.
Mr. Asante.
Mr. Asante is not responding.
Mr. Asante is not responding. Please check the vitals.
Patient connected to cardiac monitor. SpO2 94.
Oxygen.
Please, which delivery device should I use?
SpO2 is 80, 85.
Non-rebreather. Okay. So non-rebreather max fitted, and we are giving a 15 liters per minute.
15.
Yes. Non-rebreather 15.
90%. Yes.
90%. Oxygen saturation 90%.
90 improvement. So the patient has cold, clammy.
No, you don't need to determine that. I want to tell you that. BP.
No, he's unconscious.
I'm going to check.
Secretions in the mouth. Okay. Are there secretions in the
No,
mouth?
there are no secretions. There are some
Suction. So patient suctioning that.
So we put oropharyngeal.
We can't roll, we are still.
Sorry?
We put oropharyngeal.
Accepted. Yeah.
So still no rebreather max fitted. Please, what's the saturations now?
Saturation has gone up to 91%.
91.
I'm checking BP.
Vital signs. BP. What's the BP?
Blood pressure
80/40
is 60/30. With a
Pulse.
pulse of 150.
Patient breathing anywhere.
So we have to check.
Yeah,
So large well cannula inserted gray and 1 liter of saline given. Ringer's given.
The patient has some
So
bleeding
remove
at
the
the
whole dress.
There's no bleeding there.
We can't move our saturations. He says just 91, so let's concentrate on the airway. So please, what's the saturations now?
Intubate this patient. Patient intubated.
Okay.
Let's continue. Where you go next?
So breathing.
Breathing. Okay.
So check. So are there any injuries on the chest?
If the chest is rising and
No,
falling.
okay, so let's take it one after the other. So who is talking?
Group leader.
Rise
Okay.
and fall of the chest.
Yeah, but it's a little bit decreased on the left side.
Okay.
Okay. How is the carotid?
Carotid, what?
How is the no?
But have you palpated? Let me see you palpate. Yeah. So the trachea is not deviated. It's not deviated.
There are no
Any
jugular
tenderness?
veins.
Sorry? How will I know? Patient is unconscious.
Doc, is there any jugular veins distended?
There's no, well, there's some slight jugular venous distension. Very slight.
Okay,
So
so
can we
It's difficult to
percuss
see.
them?
It's really
Can
difficult
we
to see because
percuss?
you passed your.
So can you percuss to see if
The affected
Lung sound.
Hyperresonant, no. Resonant, hyperresonant, hyperresonant, resonant.
Then, okay, so please, what's the breath sounds?
Have you listened?
Yes, please.
Okay.
We've
So,
listened.
no, so listen, let me see how you listen.
so with the stethoscope?
Okay, yes, stethoscope, yes, okay, you're listening, okay.
No breast.
Vesicular, absent,
Do you have
absent, vesicular, vesicular, absent.
Action. So then I think it's more of a tension in motor
Okay.
per our symptoms. So
Okay.
we want to do a needle decompression
Okay.
at the second intercostal space,
Or-
mid-clavicular,
or-
or fifth intercostal space, mid-clavicular.
No,
No,
that's
I
not
have-
Mid
Ah.
between the mid axillary and the anterior axillary.
Those.
Okay. between the anterior axillary. So no. Those ones are just supposed to teach you like
where the ones
of this triangle. So this is it. Let me show you this one. So this is it. So this side, this is the lateral edge of the pectoralis.
Okay.
There will be somewhere here. Your latissimus dorsi will be somewhere here.
Okay.
And then this will be the armpits, and then somewhere here will be the ribs. Okay. So you're going to. So this is anterior axillary, mid axillary, posterior axillary. So it's between the mid and then the anterior axillary, somewhere here.
Okay.
So
how do we state it? So
in the fourth or fifth intercostal space between the anterior and axillary.
Okay, so between the anterior and the
Alright.
So if you are doing,
So once you did it, now you recheck your saturation has now gone out, your blood pressures are now increased. Alright, thank you very much. Alright, let's quickly do a logo for this patient. Now the rest of the program, let's do a logo for this patient.
You want the head.
So whoever takes the neck is in charge. So please come. Please, we are not growing this patient. Let's see how you do it.
So who is assessing the back?
Please, can you all see? No, please come this way.
You are assessing the back.
So please come this way. So that
team leader is at the head.
Yeah, team leader will assess. Okay, alright. So let's go. Let's see how we log grow this patient. You are log growing this patient as a log. Okay? Right.
Okay.
Let's go quick. So
on my count. 1, 2, 3. Palpate.
Okay, so what are you palpating for? So one, you are looking out for any injuries, any bruises, ecchymosis, okay? And then you are palpating along the spine for any step of deformity.
Yes.
Okay.
So
there's no step of deformity. Please go ahead. Yeah, please just a minute.
Okay, the back, no bruises.
Okay, and then when you get to the rectum, when you get to the back, you request for a gel, and then you do a GRE patient. All right, that's fine.
Alex, please bring the gel.
All right, so please. It's okay, it's fine. What are the principles of hemorrhage control? What's the first step? If you have to control hemorrhage, what's the first step? If you have to control, what's the first step? So you apply direct pressure. If that fails,
use your compact tonic.
no, when that fails, compressive bandaging. When that fails,
Your
compact tonic. You can then apply your tourniquet. Okay. So tourniquet shouldn't always be your first line.
Okay.
That's what I'm just trying to say. That tourniquet shouldn't be. Someone comes, the person is bleeding this way, and then the next thing is, then you guys will take, then they start tying. No,
give me set.
Apply direct pressure.
Direct pressure,
Compressive bandage, compressive bandage, yes. Then the compact, and then the cut. I hope you understand it. And then also there is.
Okay.
Just give me some few minutes. Yeah. Basic emergency care course, no?
Course, yeah.
Yeah. Say, you sure your accident is pa pi Ghana.
Okay.
Na accident is no. Say a severe. didi kind na nke say you prevent accident in sanke besi na say ntwe amba nsa na say severe the say na ama patient no enwu and say asamboni bi anto patient no and na ye pesi ehwe so that omo front line now omo patient no first no make me bibi afa ho ansana patient e bi as say refer ko be fufuro cry ya friend akọ baby nti sa no man na ye che say patient ne ba no man e be kum patient in tentem no say e betumi assess patient ne yehu yetumi aye bibi afa ho ansana say refer ko kesi mu a yetumi refer no nti en na ye de che front line nurses ne some doctors ne EMTs.
Okay, then Sarah yet me patients who go through such accident.
Nti me say patient enya accident e bia inframa e betumi gina ne bo inframa na ni na hrawa na ngasa mu ewo na hrawa ne ho ewo ne bo a kosi bring kan tension pneumothorax bibisa no e say otumi ni ba ko wo hwe patient first etumi say tension pneumothorax ho e bia me de panie wo ne koko ha e be ma san frama na ba na afide ne home no improve na ne blood pressure na nso akọ ni na etumi improve nti no ye one of the things that you identify with the basic trauma care course na ye che no bisu ye say bia bibi a block ni minimum bia secretion na aduane bia odi ansa na mpo onya accident na aba be she ni minimum ha ba bia e block ni minimum no nti say obetumi ehu say okay bibi e block minimum no bia menye say na memfa yi ana say moja ana say secretions intosio na de gina ni minimum memfa machine suction sa moja ne intosio no na ma kwan meda ni minimum na say ye home a mframa no e fa ye minimum ansa na akoya hrawa no na say kwan ndamu a e de be kọ na hrawa no mu a ene e de asem beba nti sa ndema na yetumi identify na aboa patient no.
Okay, as health official na mo be na so mutu to civil life na photo ben na wo de ma mo
kan ne say na me kan no say anka be prevention no involve say police will be check say cars nam kwan so ye cars papa kwan na ye nam so na ye kwan papa ye say no mensa na drive no ngofo no mensa na mo drive sa nyoma no say men go speed about maybe o maka say okay ha enko more than 50 say ye make sure so obi enko more than 50 and then bua na accident na nsi na say accident ni si wie dia say ye na doctors and nurses na ye hwe patients ni ye hu sa nyoma we na yetumi ehun say okay sa problem we na ho me yes I do in fast our problem because I told you unfortunately ebi mo ho omu ni say sa do na so mo hwe na omutumi treat patient no nti say ye doctors and nurses na e be hu yetumi aboa patient na ne de toso yes ye ye efisep after prevention is accident ni sia yes yetumi ye no.
All right, but we just want to cover question.
Quality of health, okay. The quality of healthcare no ebe improve say you be training crofo nti ebi ni sa trauma care course ye ti be training crofo na sa training na ye no ye mfa patient ye de ye omu sa training we ye de mannequins and ye friend simulation no ye de mannequins na ye de kire nti ye sa de we no personnel no healthcare personnel they are getting the skill but omo nye no patients omo ye wo mannequins abaduaba ni ade so no mo nya sa skill nti say ba ni say patient beba no no mo sa skill that no mo tumi dia so training one of the main thing okay I be my healthcare people na knowledgeable about what it is that they need to do.
The omo here say benya every health facility.
Yes, e be here say benya bi apart from ha no minim say kolebu e wo bi e bia nso te say ha but em say na echi say mate say hofo enya bi I no cry so fine nti sa ehia say benya simulation centers no go betumi akọ no makọ training e wo ho na etumi aboa in the care of patients.
Okay, what before professor de kan
ye beka say this facility e wo ha ngofo e bia omu nim say your facility medical training simulation center e wo ha but is e wo ha hospitals ne other healthcare facilities e bia schools ne ade on person omu ye training no your mannequins ne ade wo ha ye tumi yes are training no nti o metumi aba ha no ma ba besua no metumi e dey ahwe patients na ye nya good outcomes out of our patients.
How many years aban some more they provided for
yeah nti aban betumi a obetumi aboa na facilities no pii no up north near no some of these facilities simulation centers no ebeba ho no betumi aboa in training the healthcare professionals.
What's your name?
Medin here, Dr. Kwame Ekremet. I'm here doing UGMC emergency.
Okay, Kwame
Ekremet. So the medical training, it's simulation is really is a method of teaching. That is a method of teaching that we use real life clinical scenarios, but this time around it's not on patients, but it's on mannequins. And by that, healthcare professionals are able to get the skill that they need to be able to take care of patients. So when it comes to this basic trauma care course that we are conducting now, we are using these mannequins to show our nurses and EMTs how to take care of trauma patients. So when trauma occurs, there are injuries that the patient may have, and they need to be able to identify these injuries and be able to intervene appropriately so that the patient will not die unnecessarily, because some of the deaths are preventable. If you're able to identify the injuries, you are able to manage the patient and then they will not die.
So what category of health personnel need this kind of training?
In terms of trauma care, every health personnel need it. But currently we're concentrating on our nurses, EMTs, some paramedics, and physician assistants for this time. There's another one that we call advanced emergency trauma care, and also ATLS, that we target the doctors themselves so that they can also get this training done for them.
You forgot to add the part or the bit where I asked how it is going to contribute to, or how it's going to help in delivering quality healthcare in Ghana.
Okay, so the training. So when you're able to use mannequin, since they are not patients, you can train larger group of people because the facilities are available. They can train larger groups of people, and the training is so important because you see, most of the times people sit in classrooms, they get the knowledge, but to practice in a team, they don't get that opportunity. But when it comes to the medical training and training center, simulation center, you're able to get that training. You're able to practice as often time as you want to practice. You can make all the errors, all the mistakes, and because it's on mannequins, it doesn't really affect the patient. So that quality is now passed on onto other health professionals, and they can better work in their facilities well.
So as far as medical simulation is concerned, or medical error is concerned, what call would you need to gather? Yeah, and any other information that you have to share.
Okay, so again, since this is the training is done on mannequins and it's not on real patients, but the simulation is like real clinical scenarios that is generated. Such training, if we have it all across our regions, would help all the training schools, because now we have nurses training colleges all over the country. In every region, almost there's a nursing training center. There are medical schools. Although most of them are in Accra, but we have medical schools in Ho, Tamale, Cape Coast. If all these facilities would have a simulation center, it will help in the training of the doctors and the nurses and the paramedics, because not everything that is taught in the classroom can be demonstrated in the classroom. You need these mannequins, you need these centers so that you can practice and practice and practice. Practice makes perfect. So that is what would help in the training of our health professionals. I would encourage and advocate that the government will have these facilities all over the country for the training of our health care professionals. Thank you. Dr.
Very very program as I am literally dealing with emergencies all the time. So learning about the primary and the secondary survey goes a long way to help us ascertain exactly what to do for the patient immediately the patient comes. So this training has been, it's like a refresher course too. Yes.
So would you recommend it to others?
Of course, it's very necessary, especially in centers where they receive a lot of trauma cases. I think it's vital for every medical personnel, doctors, nurses, to be able to enroll in these things, to be able to know exactly what to do at a specific point in time.
So mention specifically what and what training has actually helped you in yeah.
Okay, so like I said, it's a refresher course, but the part that I enjoyed so much was the intubation part. Intubation is usually something very difficult. Not everyone can do it. Even in some facilities, we would have to resort to anesthesiologists to help us. So I think we being taught um, these things actually go a long way to help us to give adequate and optimal care to our patients as and when they need it.
So you are setting it and help perform.
Oh yes, I'm 100% sure.
The name once again is
I'm Dr. Felix Kwachi.
from which facility? Thank you.
In what way has this training?
It's very helpful because there are a lot of times where patients will come and let's say they get to a peripheral facility and they're like, oh, I can't do this. Oh, we don't have this. Oh, no, take this patient here, do this. But learning this, there are a few things we can do for the patient before we move the patient to a bigger facility to save lives. Because sometimes you look at a patient and you listen to what happened from the relative, and you're like, oh, they should have done this, this, this. Why didn't they do this, this, that, this? Then you say, oh, the patient could have been saved within 5 minutes before moving to another facility. So basically, it's one of the things we have to all learn. And it's not about the money. Oh, it's expensive. Oh, I can't do it. Oh, my hospital cannot sponsor. You can also sponsor yourself to better yourself. Having certificates like this can take you a lot of places.
So specifically, what have you learned?
Okay, so specifically, what I have learned is one, I've been able to understand why when a patient comes and the patient doesn't look okay, like the patient is not conscious, what I have to do for my patient. The patient is bleeding, but I'm not able to see the bleeding. But with what I have learned, I'll be able to do 1, 2, 3, ABC to know that okay, this can stop the bleeding, and this can also help the respiration to go up. This can also help the saturation. Oh, next time if I get a new patient, I'm not going to be like, oh, I'm referring, I don't have oxygen device, so I just gave the patient nasal prongs, knowing that maybe nasal prongs is not going to give the patient the effective oxygen, maximum oxygen the patient needs, but rather I'll give the better delivery device to help in the saturation of the patient. At least that can also save my patient.
Would you recommend it to others?
That's what I'm saying. Don't think about the money. Oh, it's expensive. No, it's something to better yourself and your facility. So even if you don't get the money now, later you'll be able to be awarded.
Thank you very much. Your name once again?
Alexandra
Alexandra.
Kwachinyako. Thank you.
Practically, what have you learned so far?
Okay, so I've learned a lot today how to manage emergencies and first response to accidents, victims, and a lot, I would say.
So whatever you have learned today, how will it be beneficial to you?
To me, okay, so when somebody is rushed to the emergency unit, I will know what to do in case of emergency, accidents, how to manage airways, and then patients with pneumothorax and chest injuries. I would know what to do when the patient is rushed
You were not
in.
doing this before.
I was, but I think it has given me more knowledge and insights into how to manage such cases.
So would you recommend this kind of training to other health professionals?
Yeah, I think it's a good initiative, and then everybody needs to know this kind of training, to get this kind of training, because it will help to reduce the death and then mortality when it comes to trauma and then accidents.
I think it's also about time the government needs to come in and then show more support.
Yeah, I believe the government has to support this initiative so that everybody will have knowledge about how to manage such cases. More trainings of such should come up so that everybody will learn and know what to do in case of emergencies.
It's good we come to the hospital, but what is your advice to the general public? Some will say, I would not want to come to the hospital. So what are we supposed to do so that we don't end up coming to the hospital?
The hospital. Well, sickness, we say nobody wishes to be sick, but the healthcare system, I think nurses and doctors are friends of the society. So when you are sick, feel free to walk in, because it is because of our patient. That's why we are in the hospital. So I think when you are sick, it's best you come to the hospital for treatment, either than staying at home and then doing self medication. So everybody is welcome to the hospital.
Your name once again.
I'm Nancy Busomtriando.